What do you think are some of the best practices in managing pain for veterinary, especially oncology patients? And how would you say that compares to general pain management?
I think best practices revolve around a careful assessment of the cancer patient for all those sources of pain, remembering not to forget that just because a treatment is aimed at curing cancer, we can't just ignore the side effects of that treatment.
Welcome to the Veterinary Cancer Pioneers Podcast, the show where we delve into groundbreaking work of veterinary professionals who are dedicated to advancing the field of veterinary oncology. I'm your host, Dr. Rachel Venable, and I'm thrilled to embark on this journey with you. Hello, and welcome to the Veterinary Cancer Pioneers Podcast. I'm your host, Dr. Rachel Venable, and today I'm so excited. We are going to be talking with Dr. Duncan Lascelles, and we're going to go into pain and how not only that can affect our patients and their quality of life, but also learn some really interesting research and how it could have a greater effect on cancer in general. So we're going to dive into all this today. But first, let me introduce Dr. Lascelles. He is a leading expert in veterinary surgery and pain management. He graduated with honors from the University of Bristol Veterinary Program and completed a PhD in preemptive analgesia. His impressive career includes a surgical residency at the University of Cambridge, a fellowship in oncology surgery at Colorado State, and postdoctoral research in feline pain at the University of Florida. Currently, Dr. Lascelles is a distinguished professor of musculoskeletal health and translational pain and research and surgery at North Carolina State University and directs the Comparative Pain Research and Education Center. As a board-certified small animal surgeon, he has dedicated his research to developing methods to measure and understand pain in pets with naturally occurring diseases and aims to enhance pain control in companion animals and support analgesic development in human medicine. Dr. Lascelles has authored over 250 peer-reviewed research papers and is an active member of several prestigious pain research organizations. So much, very impressive career, lots of education. Thank you, Dr. Lascelles, so much for being on with us today.
Well, please call me Duncan, and thank you, Rachel, for having me. It's an absolute honor to be asked to be on your podcast.
Oh, well, the honor is all ours for sure. And I always like to ask people when we start, just, if you can share a little bit about your background and how you got to become a veterinarian and then also specialize in pain. You have a lot of education. So what got you into the pain side?
Sure. Yeah. Well, starting with being a veterinarian, I've always wanted to be a veterinarian. I honestly can't remember when I first decided that. That's now lost. Actually, I always wanted to be a veterinarian, go back to Africa where I was born and treat wild animals. So that hasn't quite panned out, but I have a fascinating life, and it is all around pain. I try and understand the clinical impact of pain and the mechanisms that are driving that pain. And that interest in pain started because way back, when I was a small kid, I was fascinated by memory. And then once I got into the veterinary curriculum, I was taught by a physiologist where I learned that pain and memory share many of the same mechanisms. And then later in the vet course, once I got into the clinical years, I learned that pain was such an underserved area. We really didn't know how to assess it or treat it well. And so everything came together for me. Here was my excuse, if you like, to study memory by studying pain. And there was a very good reason for doing that. And then I think the final piece of this is that my father suffered chronic pain. And, I would say he died from it. Now, he didn't die from pain. He died of a heart attack. But the person he was, died because of chronic pain. I mean, my father, the fun-loving, life-loving person that we knew, had died, had disappeared because of that chronic pain. And so I think, that was a moment where I really understood the negative impact of pain on people, and I think by extension on the animals that we serve.
Well, and I'm so sorry to hear about your father. That sounds really tough, and certainly makes sense how it made such an impression.
It did. It really did. Yes.
And something else you mentioned, memory and pain. I'd never really thought about that before, but it does make sense. You touch a hot pan as a child, you learn really quick. You remember not to do it again. So that is interesting how those two go together. And, kind of to go back to our veterinary patients, what do you think are some of the best practices in managing pain for veterinary, especially oncology patients? And how would you say that compares to general pain management?
Yeah, I think I have to say that for the cancer patient, it's a little bit more complicated because I think we have to remember for the cancer patient that pain can come from the cancer itself. Many cancers, as we all know, can be associated with pain, but pain can also come from the treatments that we use for those cancers, whether it's surgery, chemotherapy, radiation therapy. And then finally, and this is often forgotten, pain can be present in our cancer patients because of other diseases, intervertebral disc disease, osteoarthritis. And so I think best practices revolve around a careful assessment of the cancer patient for all those sources of pain. And remembering not to forget that just because a treatment is aimed at curing cancer, we can't just ignore the side effects of that treatment, particularly when they're pain. I think another best practice is a multimodal approach, and that's particularly relevant if you have multiple sources of pain in the individual patient. And then regular reassessment and adaptation of therapeutic approaches as appropriate. So I think the approach to the pain in the cancer patient is very similar to other patients. It's just I think we are juggling more, and I have to say with that overlay of the emotive issue of cancer.
You're right. There can be so much going on with our patients. You've got the cancer and the side effects and just trying to battle that. And so, and that makes sense because I do feel like most of our patients, they're old. And so they usually do have arthritis and, like you said, back disease, all kinds of things. So that's great. I like that. And what would you say are your go-to resources when you're looking at cancer pain management? What would you recommend to help guide practitioners?
That's a great question, Rachel. It's a great question because information is so easy to come by these days that we can easily be overwhelmed and not really know where to go. If anyone listening is wanting to kind of explore the area of cancer pain management and the impact of pain in cancer patients, maybe a couple of resources. One would be Withrow McEwen's Small Animal Clinical Oncology, Chapter 16 to be specific. For full disclosure, I was one of the co-authors on that with Timothy Fan, Conor Meneses, and Mike Nolan. But I think that's actually, even though I was involved with it, I think that's a pretty good resource. It covers all aspects of pain in the cancer patient. And then I would also recommend the 2022 AHA Pain Management Guidelines. Now, the focus of the information and the discussions around persistent pain really mainly pertain to osteoarthritis, but the same principles apply, and there are great resources that can be applied to the cancer patient. So those are the two places I would start and then go out from there.
Yeah, those are great ones. Certainly the Withrow McEwen, I have multiple versions behind me there.
So do I, yes.
Right? I feel like as the oncologist, that is our go-to book. So
many fabulous contributors to those various editions, yeah.
Right? Yes, it is a fantastic textbook. I always recommend that to vets, if they're not an oncologist, but they like cancer and that kind of thing. I'm always like, go to that book. In fact, when I was a vet student, Dr. Henry was my main professor, and she told me, because I told her I was interested in oncology, and she was like, well, read this textbook. It was Withrow McEwen. She's like, if you can read this whole book and you still like oncology, then I think you should specialize. So yeah, she got me reading the whole book. So I've been reading the whole book for several years.
Fabulous.
So what steps can veterinary clinics take to help improve their current pain management protocols?
Yeah, I think when it pertains to the cancer patient, what I see when I go into practices is that veterinarians are actually doing a great job of utilizing current information on pain management and applying it to cancer patients. I think when it comes to cancer patients specifically, my main suggestions or recommendations would be, remember, cancer can be associated with pain, but as we've said already, the treatment for cancer can be associated with pain, and pain may be present in those patients for non-cancer conditions. And so that's just really important to keep coming back to and keep remembering. As you move into the management of pain in the cancer patient, always be asking, what is the evidence around a therapy for pain management? And I say that because, just because we see therapies being used, we mustn't necessarily assume there's robust evidence of efficacy. Essentially, we mustn't assume that they do work. I think in veterinary medicine, we try and do our best, and we may reach for therapeutics hoping we can improve the situation, but therapeutics where there isn't necessarily a lot of evidence. And I think an obvious example of that is gabapentin. I mean, gabapentin is used like water, and there's very little evidence that it provides any beneficial effect. I'm not saying it doesn't, but I think, as we use that, we've just got to remember, okay, let's just not assume that that's going to be effective and going to provide the pain relief we need. The next recommendation would be think about assessment of that patient and reassessment as you instigate therapies. And then finally, coming back to something we mentioned earlier, remember the importance of pain. Persistent pain can kill the animal. It can kill who the animal is. And I think we also have to acknowledge and admit that sometimes managing pain may be more important than chasing a cure for the cancer. And I think, that may be a difficult thing to say on this podcast, or a difficult thing for people to hear and internalize. The patient cares about how they feel. We may care about cancer and curing cancer, but in the road to achieving that, we have to think about how the patient feels. And I think pain and the management of pain is an important part of that.
Yeah, it's a good point. And you're right. We do often focus on treatment and just, certainly in people, other people I've known in my life had to be on chemo and kind of harder regimes. It really feels like they're just pushing them to get, it's like if we can get past this. But you're right. You do really have to remember quality of life, because how much are we helping them if they're miserable the whole time? And what if they don't make it all the way through? It's tough. And your comments about gabapentin, to go back to that, because I will admit, I am someone who prescribes a lot of gabapentin. Right. Do you recommend then, like with gabapentin, just making sure like the animal is getting better? Is that kind of what you're saying? Like, I know you're saying there's not a ton of data, but if you prescribe it, just making sure, like your point number 2 of that, that they are like reassessing that it's working?
Yeah, absolutely. Yes. And I think also just remembering, well, why are we prescribing gabapentin? Is it because we're afraid of, say, non-steroidal anti-inflammatories? And then you have to ask yourself, is that fear justified in this particular patient, or is it just a blanket fear? And if we are using gabapentin, let's assess whether it's actually having the effect we hope it will have. And I don't doubt that gabapentin is beneficial in some circumstances, but I think taking that to a number of levels away from, it may be beneficial, to assuming it's beneficial across all sorts of different pain scenarios, that's what I think we have to be careful about avoiding.
Right. Yeah. No, assuming is always bad. Right? I won't go through the acronym, but we all know that it's we're not supposed to assume. So you're right. Definitely need to reassess and things. So kind of along that, what do you think are some misconceptions about pain management in veterinary oncology?
I think probably the biggest misconception, at least the one that's on my mind at the moment, is the idea of downgrading the importance of pain. And we've touched on this a few times already, but, pain is one aspect that defines quality of life. I believe animals pretty much live in the moment. And so how they're feeling at that time, that is their life. And so again, I think, as we manage cancer, we have to be cognizant of the presence of pain and cognizant of the quality of life of that individual. But I'd also maybe extend the answer a little bit into something which I'm really interested in, which is that pain is, in my mind, not just a byproduct of cancer and other diseases, but pain, the presence of pain, may actually influence the progression of cancer. And I think maybe, so that goes back to your question about a misconception. Pain is seen as byproduct, as a side effect, as something that needs to be managed. I mean, if you think back to Withrow and McEwen, chapter 16, it's supportive care, which suggests, okay, as a result of cancer, you've got these other things that you need to manage. But pain itself may actually influence cancer progression.
Yeah, that's a really interesting thought. And, Dr. Nicola Mason, when she was on here before, had mentioned that you were doing really interesting research on how pain can influence cancer progression. So can you kind of dive into that some more? Can you explain that a little bit?
Sure. Yeah, Nikki's great. I'm very, very fond of Dr. Nikki Mason. Yeah, so this concept is that pain per se, the presence of pain, may enhance cancer progression. And I'll say this a few times in different ways because it is a new concept. So we're not talking about, if cancer is worse, is more aggressive, it's associated with more pain, talking about the concept that just the presence of pain could influence the progression of cancer and essentially influence ultimate survival. And I think one way into thinking about this revolves around sensory nerves and what sensory nerves do. So classically, we think of sensory nerves as being out in the environment and sensing the local environment, and when it comes to pain, they tell us when there's a noxious stimulus or something bad happening in the environment. So we think of them as sensing, we think of all the information going into the central nervous system. What we forget is that we know and have known for decades that sensory nerves actually contribute to the local environment. So when a sensory nerve is activated, it releases, for example, vasoactive neurotransmitters into the local environment. And that's why when you say you cut yourself or damage yourself, you see what's called a flare, this red flare develop. It's actually sensory nerves being active and spitting out these vasoactive substances into the local environment. So activity of sensory nerves can influence the local environment. Then you can start to build on that through evidence that is in the literature now that sensory nerves, certainly locally, are involved in enhancing cancer progression locally. And then there are other data that indicate that the presence of pain itself in one part of the body can actually influence the progression of cancer in another part of the body.
Yeah, that's really fascinating. So sensory nerves and then progressing of cancer just from pain. So do we think that, and maybe you'll go into this, but do you think it upregulates receptor? Like, how do we know how we think that pathway all happens?
I don't think we know. I think if you look through the literature, I think you could explain this, and they're not mutually exclusive. You could explain this by looking at three different aspects. One would be, for example, that the presence of pain has some sort of a depressive or adverse effect on immune function. And that then allows cancer to progress more easily. Another way of explaining this or thinking about it would be to say, okay, the effects are all local. So we talked about sensory nerves. You can imagine an osteosarcoma that is innervated when those sensory nerves are activated. As that animal walks, they actually spit out these vasoactive neuropeptides into the local environment, and they somehow could potentiate the progression of that local cancer. Also, we've known for a long time about perineural invasion. And, that is the mechanism by which cancer cells actually invade, get under the neural sheaths of nerves and contract along nerves. And it's thought that that is a gateway to hematogenic spread. And then I think the third kind of concept to think about, and this is not very well defined, is the idea that ligands that are involved in producing pain. So think back to that osteosarcoma, there are various substances that are involved in producing pain. Those ligands could actually be promoting cancer itself locally, but also systemically. You can imagine something like nerve growth factor that we know is produced in osteosarcoma gets into the bloodstream and potentiates metastasis in other parts of the body. And then another kind of widespread concept here would be the idea that if there's pain present, the whole nervous system becomes upregulated, and it does. We've all heard of central sensitization. And so then sensory nerves in other parts of the body are more active, are more twitchy. And if there's metastasis in another part of the body, you can imagine then that there's an interaction between those metastatic tumor cells and sensory nerves in a way that can promote progression of metastasis. Now, I have to emphasize, that's not all based on data. I'm putting together pieces of real evidence but also presenting some concepts there as well. Because there's no doubt, if you start to look through the literature, there's no doubt that pain in some way is able to promote the progression of cancer.
That's really interesting. And can you describe some of those studies that have shown how pain can influence that distant cancer progression?
Sure. Yeah. The ones that first came to my attention, and I think actually these studies, about half a dozen of them by Page and co-workers in the late 1980s, early 1990s, they were really the first studies. They caught my attention. And what those investigators clearly showed was that in rats that underwent laparotomy, had surgical pain, the retention of cancer cells in the lungs was increased. And that retention of cancer cells in the lungs was mitigated by the use of perioperative analgesics. And it didn't appear to be simply an effect of the analgesics themselves. They looked at morphine, they looked at local anesthetics, because they used the appropriate control groups, animals that were just anesthetized, had the cancer cells injected, and then had the analgesics. So with all the appropriate control groups and so on, I think there was very clear evidence from those studies that there was something about pain, perioperative pain, that was influencing the retention of these cancer cells in the lungs. So those are the first studies that influenced me. And then much more recently, working with Dr. Mike Nolan, a friend and colleague here at NC State, and work done by Connie Meneses, who was a shared graduate student, we produced more evidence of that relationship between pain and cancer progression. And so Mike had developed a model of radiation-associated pain of the tongue, or RAP for short. So he'd taken these little mice and irradiated the tongue, and that radiation-associated mucositis is associated with pain, and he demonstrated that. So this model of radiation-associated pain. In that model, what we did was at the time of maximal RAP, so maximal radiation-associated pain, we injected 41 cells into bulb C mice. And again, with the appropriate control groups and so on, what we found was that the time to metastasis was shorter and metastatic burden was greater in mice that had radiation-associated pain. So again, just to sort of think about it visually, you've got this radiation-associated pain in one part of the body. We're injecting these 41 cells into a tail vein. They float around, they go to the lungs. If there is RAP present, so radiation-associated pain present, the metastatic burden is greater in those mice. Okay, so that's interesting. And it didn't hold totally true for other cell lines. It didn't hold true for B16, F10 cell line. It did hold true for a MOC2 cell line. So there's some differences there. But maybe most interestingly, lung tumor growth was normalized when RAP, radiation-associated pain, was reduced by treatment with narosynthroid toxin, is this toxin that knocks out or knocks back a large proportion of the sensory nerves. So essentially what we showed was that phenomenon of pain-induced enhanced cancer progression was mitigated, was taken away if we knocked back or out of play a large proportion of the sensory nerves. So again, I think establishing this link between pain, or at least sensory nerves, and metastatic growth of cancer cells. That was a lot of information. I'm sorry, but
well, it's all very interesting information, and mouse data. I mean, that's really where we've got to start, right? Most of the time, but it doesn't always translate into, certainly not people, but not always animals. Like bigger animals, like dogs and cats. So, is there evidence that pain affects cancer development in dogs?
Oh my goodness. I'm glad you asked that because it is a really important question. And I think going back a number of years, what I had seen with my interest in surgical oncology was a shift from a time when, think of an osteosarcoma in a dog, and we're talking about limb amputation, and most people would have agreed that survival was still pretty poor. They had to go through this amputation, and they're going to die a short while afterwards. And then later on in my career, I was seeing amputations performed, dogs recovering very well from those amputations and actually living longer than the standard median survival in textbooks. And I think the difference, from my perspective, was pain management. And so let me talk about another study, again, done with Mike Nolan. I have to credit him for leading this one, where we looked at the effect of procedural pain on survival in dogs with limbal osteosarcoma. So we took a cohort of dogs that had been amputated for limb osteosarcoma. Now, this was a retrospective study across 2 institutions, NC State and Colorado State University. We didn't have contained assessments of pain, but what we did have was a surrogate measure, the intensity of perioperative analgesia provision. We looked at this in a number of ways, but the simplest way we looked at it was we said, okay, let's define a group of dogs that have a low level of perioperative pain management and a group of dogs that have a high level perioperative pain management. So we defined low level as those dogs didn't get a non-steroidal anti-inflammatory, either pre, intra, or post-operatively, and no local anesthetic use or a line block at best. Then the other group was, we said, okay, dogs have to have a non-steroidal both before, covering, and after the surgery, and a local anesthetic catheter. That's one of those like soaker catheters that's put into the wound, and you can instill local anesthetic every 6 hours or so for several days. So that was the high. Good coverage with a non-steroidal, solid coverage with a local anesthetic, plus or minus any other local anesthetic use. And when we looked at the effect of low versus high provision of perioperative pain management, we found a significant difference in overall survival. The high level of perioperative pain management resulting in a survival almost 100 odd days longer than the low level. So a very significant separation of those groups. So to me, I mean, I'm fascinated by the mouse data, but this is really exciting because this is meaningful. This is the type of patients that we deal with, that we care about. And I think very solid evidence suggesting that there is something about pain here, procedural pain associated with amputation, that is affecting ultimate survival.
Yeah, wow. So let me just make sure I'm getting this right. So dogs with osteosarcoma getting an amputation, if you found that they've got more aggressive pain management, perioperative, and sounds like afterwards too, so like NSAID, soaker catheter, they live longer. So why do you think that is?
Yeah, again, I have to admit, I don't know. But I'm going to come back to kind of the concepts. And so, one reason could be that the presence of perioperative pain has a negative, deleterious effect on the immune system. And the immune system is just not as good at dealing with the metastatic disease, which we know is present at the time of amputation in dogs with osteosarcoma. Or it could be something to do with what's happening locally, that in a pain state, there are going to be local ligands that drive pain, whether that's calcitonin gene-related peptides, substance P, nerve growth factor. And if we decrease pain, there are going to be less of those ligands. And those ligands, which may also promote cancer, then are not going to get into the systemic circulation. And then the final area would be, well, maybe by managing pain perioperatively, by managing it well, we're decreasing the chances of getting into this sensitized state where nerves throughout the body have heightened activity, heightened awareness, and potentially could play an active role in the progression of cancer at other sites in the body.
Yeah. Well, and what do you think about just owner perception of quality of life? Do you think that played a role? Like if the dogs didn't act as painful, that's the other reason why the owners maybe went longer? Was there any way to factor that in with that study?
That's a good question. So I'll be honest, I think that's something that needs to be revisited in a prospective study to confirm these findings, or try and confirm these findings. But I think also just thinking about the median survival times, you're talking, I forget the exact figures, about 250, 260 days in the low-level group, and 100 days later in the high-level group. So we're not talking about how these patients were in the immediate days, weeks post-operatively, making a difference to ultimate survival. So it's something that's having a longer term effect other than just say how they're recovering from that amputation. But these are important things to think about as we move forward is, let's not make assumptions. Let's keep asking questions about what is actually driving the differences that we see.
Well, it also makes me wonder about some of the studies where, it's looking at osteosarcoma, dogs treated with amputation and chemotherapy, and there's studies looking at the same chemo drugs, like carboplatin or things, but the survival's not quite the same. And it almost makes me wonder, was pain management, could that be some of the difference between why some studies, carbo performed a lot better versus at another study, it didn't. I'm sure there's lots of factors, but now it's just making me wonder, like, oh, what if those dogs didn't have good pain management? Like what, so it's just so many different levels, so many things happening to think about.
Right. Yeah. And I think, as we do more of these studies, we observe more, we learn more, and then we can test more theories in subsequent studies. And it reminds me of yet another study that myself and Mike Nolan were involved with. And this one's very much run by Mike. He wanted to look at stereotactic radiation therapy versus conventional and a couple of different doses of stereotactic radiation therapy. We added on looking at baseline pain severity in those patients. And when we looked at the results, there were some no-brainers in terms of results. If a dog started radiation therapy and chemotherapy for osteosarcoma, these were dogs with osteosarcoma again. If they started radiation therapy and chemotherapy but had metastasis, they didn't live as long. So it's like, well, of course, the tactic radiation therapy was associated with better survival than conventional radiation, and a larger dose of stereotactic radiation therapy was associated with better survival. But interestingly, both in univariate and then again in multivariate analysis, baseline pain score affected survival, with higher pain scores leading to shorter survival. Now, there's a situation where I think, one of the first questions one would ask is, well, was that because the disease was more aggressive or worse at the start in those patients? So I think that, these are things that do need to be revisited. But again, it does add to this body of growing evidence that there is some sort of negative effect of pain per se, on cancer progression. And I just want to, sorry, I'm talking a lot, but I just want to touch on one other fascinating study that was published in Nature a few years ago. And it was all about gliomas in people, so nasty brain tumor in people. And I don't remember all the details, but what I do remember was that these gliomas formed synaptic and electrical connections with neurons in the brain. And if the neurons in the brain were active, that enhanced the development of these gliomas. And so to me, it's a crazy example of a cancer cell, having a connection with a neuron and having that neuron to affect its own survival and development.
Yeah, that is wild to think about. And so I guess part of the next question with all this is, how important is early pain intervention in the treatment, especially for oncology patients? What indications should vets look for?
I think, if we believe that pain has a negative consequences on cancer treatment outcomes, then the follow-up question should be, well, what is the optimal time to intervene? We honestly don't know. But I am reminded about the work in my PhD that was looking at surgical pain and central sensitization. And I found, and others have found the same thing since, that the earlier we intervene, the future is better. If we prevent signals from going into the system, we can improve outcome later on. And I suspect as this field develops, we will conclude that early treatment of cancer pain has a greater beneficial effect on cancer treatment outcomes than later treatment of pain. At this stage, I would propose that early treatment is better.
Right. Not waiting until they're in a lot of pain, but just starting things early on. So that makes sense. So how do you think effective pain management correlates with client satisfaction and just them sticking with the protocol or just the plan for their pet's treatment?
That's a really good question. So I think effective pain management is important for client satisfaction. My experience is that clients very much appreciate clinicians that care about how their patients feel, including comfort. And so when you start to acknowledge that, I think you have a greater connection with clients. But I think education's needed. I don't think owners always know what pain is. I think for many owners, pain means vocalization, screaming, writhing. They think of these very dramatic scenarios. And so I think we need to educate owners as to what the signs of pain may be. Now, owners know what they're seeing. They just need to be educated that what they're seeing may be associated with pain. At the same time, I think we need to educate ourselves that there are many signs of pain that sometimes we overlook, particularly in the quest to cure cancer. So I think education is really important, and acknowledging to owners that we care about pain and comfort. And then I think you have a much stronger team. The treatment team and owners, a much stronger team to get through the course of treatments that are needed.
Yeah, and I agree. I think owners like when you talk about, managing their pain or, different ways, different modalities to do it. But I also agree that a lot of them really don't understand what pain looks like in animals. And I think too, because animals will often hide it. It's rare that they truly vocalize and, they can't have a chat about how they feel like a person could. So I totally agree. It is really hard for people. And I think education is a huge part of it. And so, as we've been talking, so cancer causes pain and cancer treatment, can lead to pain. And we're also now thinking, from what you're saying, potentially the presence of pain per se can even, have a role in cancer progression. So how do you recommend that we really detect this level of pain? What should we do to treat it? Anything different? Would you do anything different with cancer patients? How are you now with all this information and research you're doing? How are you approaching these guys?
Yeah, great. So, if we acknowledge that cancer can cause pain, our treatments for cancer cause pain, and further acknowledge that the presence of pain can have an impact on the progression of cancer, then we have to take management of pain seriously. And that's honestly, Rachel, where we need a lot more work. So the pain management field has developed methods to assess pain, and some methods to assess cancer pain have been developed, but we need more. We need validated assessment methods across the different types of cancer pain that can measure the effect of cancer pain in different parts of the body. And the validated assessment methods I'm talking about, essentially client-reported outcome measures or client questionnaires, owner questionnaires, but they could also be clinician questionnaires as well. So capturing what we can all see, the behavioral indices of pain on paper through targeted and valid questions. And once we have validated assessment tools, then we'll be able to make headway in understanding what are the best approaches to treat cancer pain. At the moment, the treatment of cancer pain is pretty much empirical. We say, okay, these therapeutics, these non-drug therapies work in other pain conditions. We've got some evidence for that. Let's try them in our cancer patients. It's not all doom and gloom. A number of teams are making progress around cancer pain assessment and understanding what most effectively manages cancer pain, but we need a lot more work in this area for sure.
And what are some trends or new technology in pain assessment do you think oncologists should be aware of?
Yeah, I think the one that leaps to mind is leveraging video and artificial intelligence. So I mentioned earlier that cancer pain is manifested through behavioral change. And as subtle as those may be and as difficult to recognize, as we make progress, we can train computers to do that process more quickly, possibly more consistently as well. And so that's what I mean by leveraging AI there. We basically take what we know, train a computer algorithm to do it more consistently, to do it faster. Beyond that, potentially, there's a very exciting future in what you might call a black box approach, where you feed information into a computer and ask it to parse out the information into different groups. And through those processes, we may actually advance the measurement of pain into areas that we didn't even know were possible. It's like, everyone answering that question is going to talk about AI, but it is going to make an important impact to the field of pain assessment for sure.
Right. I hadn't thought about it in that way, but that is really interesting. And, one thing, just kind of thinking of some drugs that I just want to ask you briefly, you mentioned in that study with Mike Nolan with the mice and the rap, and when you gave them the drug that I can't remember how you said it, that deadened sensor, is that something commercially available or veterinary, or is that still in the research stages?
Yeah, so we were using that drug, and it's called racinoferritoxin. It's basically capsaicin on steroids. It's a very, very powerful TRPV1 agonist. So it overstimulates sensory nerves, overstimulates them to the point where they burn out and even die back. And so we were using that as a tool. I think there is a lot of interest, though, in TRPV1 agonists, things like capsaicin, applied locally or regionally to knock back the sensory nerves so that, one, pain is decreased, but also then, you don't have those deleterious effects of pain in those cancer patients. So I think there is certainly interest in that group of drugs for sure.
But it's not something you can really buy, or do you know, is that still research level?
I'd have to say it's pretty much, yes, it really is research level. Yes.
Okay,
there's always a way of getting hold of something, but no, it's research level. Yes.
Right. Okay. All right. Perfect. And then one other drug that I know I get asked all the time, all veterinarians, Librela, those new monoclonal drugs. What are your thoughts on that? And just, cancer pain management or just pain management, do you use that, or what would you recommend for veterinarians?
Yeah, so Librela, which is Bedinvetmab, is the first anti-nerve growth factor monoclonal antibody approved for use in dogs, and Frunevetmab, or its trade name Silencia, is the first anti-NGF monoclonal antibody approved for use in cats. Now, they are approved for osteoarthritis pain, and I think there's very strong evidence around their utility for osteoarthritis pain. That said, and I think I've mentioned it a couple of times, nerve growth factor is known to have a role in cancer progression for a number of cancers. And nerve growth factor can drive pain. And so there may actually be dual utility here of an anti-NGF approach for certain cancers, possibly osteosarcoma, possibly other cancers. So very exciting thoughts. Again, we just need to define whether there is utility and what that utility is. Because those tools are available, I know a number of oncologists are exploring their use in cancer pain conditions. So looking forward to some information in that area.
Yeah, no, that is really interesting. And yeah, I get a lot of questions and different stories from vets. So I'm just, since you're the pain expert, was really curious what your thought was. And Dr. Lascelles, it sounds like you are doing a lot of exciting things in your lab, all this different research. It's really unique, at least to me. I haven't really thought about pain in this way. So what are some other promising projects that you're doing in your lab?
Yeah, well, I certainly enjoy what I'm doing. I've got three main areas that we're focusing on at the moment. One is looking at how the microbiome and leakiness of the gut may influence the progression of osteoarthritis and osteoarthritis pain. And that work is NIH funded in collaboration with Dr. Amanda Nilsson at UNC. She's doing the two-legged animals, humans. I'm doing the dogs. And then another NIH funded project is one where I've teamed up with Dr. Santosh Mishra, and we're looking to understand the Artemin GF-alpha-3 signaling system and its role in pain. Now, some of your listeners may have picked up when I say Artemin, because Artemin has been known for a long time to be involved in the progression of pancreatic cancer. It's a neurotrophic factor known to be a driver of pain, but also independently known to be involved in pancreatic cancer progression. So that's kind of nice work because it's bringing together my raw pain interest as well as my interest in cancer management. And then finally, I have to mention a wonderful collaboration with a project that's led by Dr. Mike Nolan. Dr. Santosh Mishra and myself are collaborating with Mike, and he's looking to understand the mechanisms of radiation-associated pain, something which we all know is difficult to manage. I know it goes away after a few weeks, but it's really difficult to manage. And so he's making great headway in understanding the mechanisms, the unique mechanisms that drive radiation-associated pain.
Oh, yeah, those all sound like fascinating studies. I love the whole microbiome. That is just really opened up into a whole new area. And yeah, and if we could get a better understanding too on radiation pain, just to, this could ultimately find ways to help prevent it, right? That's
right.
That's sort of what I'm thinking about. And I'm sure that's where Dr. Nolan's interested to go, at least I would assume. But that all sounds really great. Well, we'll certainly have to keep a close eye on your lab. And just thinking about research, what advice would you give vet students interested in research, or just veterinarians in general?
Yeah, so from my perspective, research is a wonderful way of helping many animals beyond just the one in front of you. And I'm not downgrading, belittling the, working on an individual animal, one pet at a time. That's desperately important. But research is just another part of the jigsaw. And through research, you can potentially help many animals. So I think that's one of the things that draws me to it. And anyone wanting to get into the area, I would say just start talking to people. Talk to lots of people. Develop a passion. Understand what the problems are. And even if you don't know what the solution is, aim to find a solution. It can be extremely rewarding.
I love that. That's perfect. And along with that, what would you say is the most rewarding part of your career?
Oh, I think it's seeing my research actually make a difference in practice. First and foremost, I'm a veterinarian. I love animals. I want to improve our ability to manage those animals and optimize their quality of life. And so, when I see my research make even a small difference in practice, that is really the most rewarding part of my career.
This has been an awesome conversation. And as we're wrapping up, just, a question I always like to ask everybody, who else would you recommend that you think would be a good fit for this podcast?
Wow. All right. If we're on the pain topic, then a couple of names that jump to mind would be Pat Manti and Brian Schmidt. So Pat Manti is a basic pain researcher who really, he didn't invent, but he really gave a kickstart to the cancer pain research field. So he would be a great person to have on your podcast. Brian Schmidt is an oral surgeon, he's human. He treats humans. He's a surgeon for humans around oral head and neck cancer. And he's done a lot of research into the mechanisms of head and neck cancer pain, and could also speak on the effect of pain per se on cancer progression. So those would be a couple of pain individuals. I think one thing worth mentioning is I think it's always important to listen to stakeholders. And so I would also suggest owners of animals who have suffered cancer or suffered cancer pain, maybe even have them all as a group. What were their experiences? What were their thoughts? Because I think, we veterinarians can live in our little bubbles and talk to each other, but we do need to pay attention to the important stakeholders, the owners of the pets that we're treating.
Yeah, I think that's a great idea. And we do often forget about that element too. So I think that's great. And well, Dr. Lascelles, thank you so much. This has been such a fascinating conversation. And I know our listeners are going to love it. I learned a lot. So thank you so much.
Well, thank you very much, Rachel, for having me. It was an honor, and I enjoyed talking to you.
Well, that's it for this episode of the Veterinary Cancer Pioneers Podcast. If you enjoyed this episode and gained valuable insight, we would be so grateful if you could share our podcast with your friends and colleagues. And it would be even more wonderful if you want to give us a 5-star rating, positive review, or any kind of feedback on Apple Podcasts or wherever you listen. The Veterinary Cancer Pioneers Podcast is presented to you by Invermed.